Hello, everyone, and welcome back to our question lab. If this is your first time, welcome to our question lab. If it's your second time or third time or more, welcome back. We're happy to have you here. Today, we will be covering reproductive physiology, and we're glad that you guys are here and able to join us. My name is Sean. I've been with RX Coach for almost 2 years, and we'll talk about RX Coach a little bit later. We have some wonderful panelists joining us today. And if you look at the right side of your GoToWebinar control panel, you will see a question box, and you're able to ask questions there, and we will do our best to answer those questions for you. Leading tonight's discussion is future Dr. Kasia Bronstein, and I will let Kasia introduce herself.
Hey, thank you, Sean. So hi, everybody. I hope you all are doing well. I'm a fourth-year medical student here in Miami, Florida. Prior to medical school, I graduated from the Tulane Pharmacology Master's Program in 2017, and I worked in EMS as a paramedic and paramedic educator for several years. I've been working as a study coach and tutor with the RX Coach project for over 6 months now, working with students one-on-one mainly regarding preparation for Step 1, but also in helping students build content knowledge for school exams, shells, and COMLEX. This is my third QLab, and I absolutely love working with y'all to help build confidence and knowledge to tackle these big exams.
Excellent, thank you, Kasia. Now that you've had a chance to meet us, we have some panelists also, Kate and Jeff, who you'll meet later in tonight's session. But now that you've had a chance to meet us, we would like to get to know you. So please let us know, who are you? What type of medical student are you? Are you a graduate? Are you a dental student, a podiatry student? We'll give you a few seconds to respond, and then we'll get started. Keep in mind that this poll format is the same format that you will see for all 4 of our questions today. We'll have you submit your responses just like you are right now. So we'll give you guys a few more seconds to respond, and then we'll get started. All right, looks like the responses are starting to come in. We'll give you guys a few more seconds. All right, let's see. So it looks like 71% of you guys are international medical students or graduates, and 21% of you guys are US or Canadian born international medical students or graduates. So that's over 90% of you guys are at international schools, and we're happy to have you here. And we hope that all of you find tonight's session with Kasia to be a helpful one as we discuss reproductive physiology. So with that being said, we are going to be the methodology that we use in RX Coach. RX Coach, like I mentioned briefly earlier, is our new one-on-one tutoring and coaching program. What we do is we work with students to analyze their strengths and weaknesses, build a customized study plan, and then implement that study plan with you. So we work on knowledge and content as well as test-taking skills, and then towards the end, we start working on timing and stamina as well, really hitting the exam and medical school exams as well as board exams on all fronts. So we'll talk more about that later, but the methodology we're using today is the same methodology that we use in RX Coach. So without much further ado, we're going to go ahead and get into the first question of the evening. Make sure you stick around till the end. We do have a raffle. 3 lucky winners tonight will receive free and complimentary access to our resources. That's a great value, so make sure you stick around because you must be present to win. You must be present to win. So with that, let's go ahead and get started with the first question. Now, as you guys can see, the answer choices are missing, and that is by design. We cover up those answer choices on purpose because we don't want these answer choices to guide or dictate your thought process. We don't want these answer choices to cause you to panic if you see a choice that you're unfamiliar with while you're doing this question. So we don't want you to be jaded by them. So we cover those up, and after we cover up those answer choices, we read the lead-in or the last sentence of the question itself together and out loud. Which of the following will most likely be affected immediately? Which of the following will most likely be affected immediately? And once we read the lead-in, we like to ask the students in our coaching sessions, what's important? What is this question asking? We can't do that with each of you individually today, but what I will ask you to do is let me know how many steps you think this question will take. An example of a 1-step question could be where they ask you for a diagnosis. An example of a 2-step question could be where they ask you what is the treatment for a diagnosis. And An example of a 3-step question could be where they ask you, what is the mechanism of action for a treatment, for a diagnosis? So with those examples in mind, please let us know in the question box how many steps you think this question will require. We'll give you guys a few seconds to respond, and then we will continue with our first question of the evening. Looks like a lot of people are saying, some people are saying 2 steps, some people are saying 3 steps. And don't worry, Kasha is going to go over that with you as we go through this question here together. The reason why we have you let us know how many steps each question is because we want you to have an organized thought process, so that if you can get from A to B and B to C in an organized manner, so you're actually answering the correct question and not missing any steps or falling for any test writer traps. So now that we've done that, let's go ahead and read the vignette together. Now, in the coaching sessions, the coach will stop you after every sentence and ask you what's important, what do you want to highlight, what are you thinking? But we can't do that with you individually here today. So what I will do is I will pause briefly after each sentence to give you a second to gather your thoughts. So here we go. A healthy 21-year-old woman with no history of significant illness comes to the physician requesting combination oral contraceptives. She is sexually active and always uses condoms as contraception. No abnormalities are noted on physical examination. The result of a urine test for beta HCG is negative. She is prescribed a combination oral contraceptive. Which of the following will be affected immediately? And with that, I will turn it over to Kasha.
All right, thanks, Sean. So as Sean mentioned, we recommend several different techniques to ensure that students can do their best when answering questions. After figuring out how many steps we think this question is asking, we like to go ahead and review the answer choices. Now, when we talk about answer choices and going over them, we like to start at the bottom. And the reason we do this is because we don't want to become biased, as Sean said, by something you see early on. And working your way up from the bottom ensures that you get through all the answer choices. So we're going to go ahead and do that now. E, ovulation. D, mid-cycle surge of luteinizing hormone. C, fertilization of ovum. B, change in estrogen concentration during the follicular phase. Or A, blastocyst implantation. So go ahead, we'll give everyone a chance to take a look and think about their answer choice, and then Sean's going to open up the poll.
Excellent. So let's see how you guys did. So it looks like 53% of you guys picked change in estrogen concentration during follicular phase. And in second place was mid-cycle surge of luteinizing hormone. Let's see what the correct answer is. And the correct answer is B, and 53% of you guys got it right, so well done. I'm going to turn it back over to Kasha so we can go over the incorrect and correct answer choices.
All right, thank you, Sean, and nice work, everybody. So let's go ahead and look through this question and pick out the pertinent information that we need to identify why that answer choice was the correct answer. So this vignette features a 21-year-old woman presenting to the physician for oral contraceptives. This question comes down basically to, I think, 2 steps. Basically, what is the mechanism of action of combination oral contraceptives, and what is their effect on the hypothalamic pituitary gonadal axis to produce effective contraception? Okay, so to understand the mechanism of action of OCPs, it's helpful to understand the hormonal changes that occur in the normal menstrual cycle. The normal menstrual cycle consists of the follicular phase, which is usually around 14 to 21 days, and the luteal phase, which is about 14 days. The follicular phase begins after the onset of menstruation and is characterized by FSH, that's follicle stimulating hormone, stimulated growth of 1 or more follicles that release estrogen. Estrogen causes the uterine endometrium to enter the follicular phase, which is characterized by a thickened endometrium with an increased number of glands. For most of the follicular phase, estrogen also works to exert negative feedback on FSH and luteinizing hormone, or LH, production. But late in the follicular phase, high serum estrogen begins to have a positive feedback effect on LH production, which leads to the LH surge, defined as a 10-fold increase in the serum LH concentration. One way that I like to think about this that helps me remember this important concept is, during which phases of the uterine cycle is the best time for a developing embryo to implant in the endometrium? So take a moment to think about that and share that in the chat. Which of the following, or excuse me, which phase of the uterine cycle is best for a developing embryo to implant in the endometrium?
Excellent. We'll give you guys a couple of seconds to respond here. We've got a lot of people saying luteal phase.
Okay, awesome. So that's absolutely right, and nice work, everybody. While it is possible for a developing embryo to implant at multiple different time points throughout the uterine cycle, the most opportune period is during the luteal phase. The LH surge characterizes the start of the luteal phase and subsequent ovulation. The oocyte of the dominant follicle completes its first division, its first meiotic division, and is released from the follicle about 36 hours after the LH surge. The remnant follicle becomes the corpus luteum, which releases progesterone in the mid to late luteal phase. Progesterone causes the endometrium to cease thickening and causes glands to organize, which is described as secretory endometrium. The corpus luteum begins to resolve in the late luteal phase, which occurs when LH release declines via a negative feedback mechanism from the rising serum progesterone concentration. As the corpus luteum resolves, serum concentrations of progesterone and estrogen decrease, and that results in the loss of endometrial blood supply, endometrial sloughing, and that brings us around to the onset of menses. So, why is all of this important in the context of OCPs? Combined OCPs consist of the two hormones, progesterone and estrogen. Progesterone provides negative feedback to decrease the release of gonadotropin-releasing hormone from the hypothalamus, and that decreases the secretion of FSH and LH by the anterior pituitary. The immediate effect of decreased FSH is to inhibit follicular development, and that prevents the increase, and to prevent the increase in estrogen concentration during the follicular phase. Without the end follicular peak in estrogen concentration, positive feedback with LH release can't occur, and thus the LH surge cannot happen. Without the LH surge, ovulation cannot occur. Okay, so with all that said, let's talk about why the other answer choices are incorrect. We'll start from the bottom up with E, ovulation. Although the decreased concentration of FSH leads to the downstream effect of ovulation inhibition, ovulation is not the process that's most immediately and directly affected by the decrease in the FSH concentration. D, mid-cycle surge of luteinizing hormone. Now, although the decreased concentration of FSH does lead to the downstream inhibition of the LH surge, again, is not the process that is most immediately and directly affected by the decrease in the FSH concentration. We'll talk about C, which is fertilization of ovum. Now, OCPs decrease the FSH concentration, which prevents fertilization only indirectly by way of ovulation inhibition, because fertilization cannot occur in the absence of an ovum. Unlike OCPs, IUDs work, intrauterine devices, work primarily by inhibiting fertilization. Progesterone released from hormonal IUDs does thicken the cervical mucus to prevent sperm from reaching the fallopian tube, and copper IUDs contain copper ions that act as a spermicide, which directly prevents sperm from fertilizing the ovum. Okay, and lastly, we'll talk about A, which is blastocyst implantation. During the luteal phase of the menstrual cycle, progesterone prepares the endometrium for blastocyst implantation via formation of secretory endometrium. secretory endometrium is characterized by organization of the endometrial glands, intertwining of the endometrial glands with the arteries, and edematous endometrial stroma. Okay, and copper IUDs may work to prevent implantation of the blastocyst, but that's not how OCPs function. So again, the most direct effect of OCPs is to decrease FSH, inhibiting follicular development and preventing the increase in estrogen concentration during the follicular phase. All right, nice work, everyone.
Awesome, thank you guys. Great job. And thank you, Kasha. We got our first question out of the way. We've got 3 left. You guys did a great job there. Let's keep the momentum going with question number 2. For those of you just joining us, I'll go over the process with you guys again. This is the same methodology that we use in RX Coach. And as you guys can see, the answer choices are covered up. That is by design. We don't want the answer choices to dictate your thought process. And we don't want you to see an answer choice you might be unfamiliar with that causes you to panic as you read the questions. We cover those answer choices up, and then we read the lead-in together. In addition, which of the following secondary sexual characteristics would this patient most likely show? In addition, which of the following secondary sexual characteristics would this patient most likely show? So I'll give you guys a second to let us know if you think this is a 1-step, 2-step, or 3-step question, and let us know in the question box. All right, and it looks like you guys are responding. And as always, Kasha will go over how many steps this question requires when we go over the answer choices. So now that we have read the lead-in, let's go ahead and read the question stem together. A 7-year-old girl is brought to her pediatrician because of lower back pain. The patient's mother mentions that she has recently gone through a growth spurt of 4 centimeters or 1.6 inches. And the patient says she is now taller than all of the boys in her class. The pediatrician proceeds with a complete physical examination, which reveals development at Tanner stage 3. In addition, which of the following secondary sexual characteristics would this patient most likely show? And with that, I will hand it off to Kasha.
All right, thank you, Sean. So let's talk again about how many steps this question should be, because we want to maintain focus on what aspects of the vignette we need to pay most attention. So this question is asking us to identify what secondary sexual characteristics are present during Tanner stage 3, which to me seems a fairly straightforward 1-step question. So let's go ahead with those answer choices. And once again, we'll start at the bottom and work our way up. All right. E, lack of pubic hair and flat chest with raised nipples. D, downy pubic hair and initial formation of breast buds. C, coarse pubic hair extending to the medial thigh and flattened areola. B, coarse pubic hair and raised areola. Or A, coarse pubic hair and enlarging breasts.
Excellent. So we'll give you guys a couple of seconds here to respond and select an answer choice. We'll give you guys a couple seconds here. This is a question that is an important one, and reproductive physiology is one of those topics that can be challenging for students, but hopefully after today you'll have a better understanding of the topics that we're going to be discussing. So we'll give you guys a few more seconds. As always, make sure you stick around until the end because we do have a raffle, and we'll have 3 lucky winners this time. 3 lucky winners this time. Excellent. Looks like you guys have submitted your responses. Let's take a look. And it looks like 46% of you guys picked answer choice A, or coarse pubic hair and enlarging breasts. And in second place, with 20% of you guys selecting the answer, was choice B, which is coarse pubic hair and raised areola. So with that, I will turn it over to Kasha so we can go over the correct and incorrect answers.
All right.
Kasha.
So, go ahead.
So as you guys can see, the correct answer is A, and 46% of you guys got that right. And with that, we'll hand it back off to Kasha.
All right. So, thank you, Sean. Nice work, everyone. So let's go through this question one more time and identify the pertinent details in this vignette. This is a 7-year-old female patient with growing pains, noted by the physician to be at Tanner stage 3. Which of the secondary sexual characteristics would this patient most likely show? This question requires you to have a ready knowledge of the features present at each point in the Tanner staging system for sexual development. In females, Tanner stage 3 usually occurs at around 10 to 14 years of age, so this degree of sexual development may be a little on the early side for this patient. Now, during Tanner stage 3, the breasts will begin to widen, but there's no sign of contour separation. In addition, the areola will further enlarge and become darker. Pubic hair will become darker, thicker, and cover the mons pubis. Most girls will experience their most rapid growth spurt during Tanner stage 3, a key point in this question. Additionally, axillary hair may be present. I find it easiest to commit Tanner staging to memory by recognizing Tanner stage 1 and Tanner stage 5 as the extremes of development, and then fill in the middle stages. So let's go through each of the other choices and identify what may be present at other Tanner stages and fill that in. So, E, lack of pubic hair and flat chest with raised nipples. So this is by definition Tanner stage 1, which is prepubertal. In Tanner stage 1, there's no glandular tissue in the breast. The areola follow the skin contours of the chest, and there are no secondary sex characteristics, such as pubic hair. We'll come up to D, downy pubic hair, and initial formation of breast buds. So Tanner stage 2 corresponds to the first signs of puberty. The breast buds will develop during the stage, and the subareolar tissue will begin to elevate and develop. Pubic hair is fine and downy and restricted to the labia majora. We'll take a look at answer choice C, which is coarse pubic hair extending to medial thigh and flattened areola. And that's Tanner stage 5. So in Tanner stage 5, the breasts achieve adult size, with each areola returning to the breast contour of the surrounding breast tissue with a projecting central papilla. Pubic hair will now also spread to the medial thigh. So this stage typically occurs in girls around 15 to 16 years old. Although this patient has a growth spurt potentially indicative of precocious puberty, she's not yet developed Tanner stage 4 findings, which is answer choice B, coarse pubic hair and raised areola, in which breast size and elevation will increase, and the areola and papilla on each breast form a secondary mound and separate from the contour line. Pubic hair will be of adult length and quality, but it will not spread to the junction of the medial thigh and perineum. Typically, females will also begin to menstruate. In females, Tanner stage 4 occurs around 11 to 15 years of age. And so that's a little bit more beyond what we saw for the patient in this vignette. Okay, so while a relatively straightforward memorization question, it's very important to know this high-yield staging system and the chart well, because these should be easy points to get on test day. All right, back to you, Sean.
Excellent. Thank you, Kasha. And great job to you guys. Once again, 46% of you guys got it right. So very well done. We're doing well today, and we're going to keep the momentum going. But before we continue, I do want to introduce you to one of our other coaches that hopped on a little bit later this evening. Her name is Megan. And Megan, I'll let you introduce yourself.
Hey everyone, I hope you can hear me. My name is Megan. I'm a third-year med student in Miami, and I'm looking forward to helping everyone out.
Excellent. Thank you, Megan. So Megan's one of our RX coaches, and this is actually her first question lab. So welcome, Megan. So RX coach, we've talked about that a couple of times. You've met Kasha, you've met Megan now. What is RX coach? So RX coach, like I said, is our one-on-one, our individualized tutoring and coaching program. And what sets it apart is the fact that, every student learns differently. You all have different strengths and weaknesses. You all think differently, and you all apply what you have learned differently. And if you really want to maximize your potential, you want to have that coach guiding you to identify those strengths and weaknesses and give you a customized and individual study plan, and then work with you on a one-on-one basis to finesse those test-taking skills. And that one-on-one attention has been so beneficial for all of our students. So we begin with a 160 question assessment. We analyze that assessment to come up with a study plan, and then we will meet with you at regular intervals to go over the subject that you are studying. You can ask your tutor questions, have things explained to you, and then do question dissections as well, so we can identify patterns in how you think and how you take a test, so we can finesse those test-taking skills and help you achieve your maximum potential on test day and help you get the residency you've always dreamed of. So if you're interested in working with an RX coach to maximize your potential, please visit rx-coach.com. That's rx-coach.com, and schedule a free consultation to discuss the program and how it can benefit you. If you want some generalized study advice and some tips, feel free to visit firstaidteam.com. And as you guys see there on the screen, we have a wonderful testimonial from a student who went up a little over 35 points in her time with us. And we hope that we can make you a success story as well. So feel free to check us out at rx-coach.com. All righty, with that, let's go ahead and get into our third question of the evening. So once again, beginning with the lead-in. The action of which of the following hormones is responsible for this change in body temperature? The action of which of the following hormones is responsible for this change in body temperature? So I'll give you guys a couple of seconds to let us know how many steps you think this question will require. I'll give you guys a few more seconds to respond here, and then we will go over, we'll read the question, and then go over the correct and incorrect answer choices. We have people saying 1 step, some saying 2 steps, some saying 3 steps. So we'll have Kasha clarify that. So now that we've read the lead-in, let's go ahead and read that vignette. A young couple is trying to conceive their first child. A friend tells the woman that she should take her temperature daily to determine when she ovulates. The woman asks her physician if this is true, and her physician explains that changes in the concentration of a particular hormone during ovulation lead to temperature changes. The action of which of the following hormones is responsible for this change in body temperature? And with that, I'll hand it back off to Kasha.
All right, thanks, John. So again, let's figure out how many steps this question requires. I'm seeing 1 step and 2 step. And I think it depends a little bit on what your knowledge or your content knowledge is prior to coming into this question. Might be 1 step, might be 2 steps, but it looks like they're asking which hormone during ovulation is responsible for this change in body temperature. And so it looks to me like likely a 2-step question here. So let's take a look at the answer choices, starting as always from the bottom up. So starting with E, progesterone. D, luteinizing hormone. C, human chorionic gonadotropin. B, follicle stimulating hormone. Or A, estrogen. All right, so once again, we'll give everyone a few moments to think about the question and their answer choice, and go ahead and select the answer choice you think is correct.
Excellent, thank you, Kasha. So we'll give you guys a few seconds to respond here. This is our third question. Make sure you guys stick around until the end, because we will have 3 lucky winners tonight, and you must be present to win. As you guys have noticed, we're going over the correct and incorrect answer choices in detail, and that's very important that you guys do that as well when you're doing practice questions. So keep that in mind. Make sure you know why you got the question right or wrong, and that you got it right for the right reasons. And you can also explain why the wrong answers are, in fact, incorrect. So I see you guys have responded. Let's take a look. Looks like 45% of you guys picked progesterone, and in second place with 31% was a luteinizing hormone. Let's take a look and see what the correct answer is. The correct answer is E, progesterone. So once again, 45% of you guys got this right. We're doing really well today, so congratulations. And let's hand it off to Kasha so we can understand why the correct answer is correct and why the incorrect ones are incorrect. Kasha.
Okay, so nice work, everyone. So I think that the content knowledge here ties a little bit into the first question that we looked at, understanding which hormones are highest during which phase of the menstrual cycle. So we can see that this patient is asking about temperature or thermoregulation related to hormonal changes. So maybe a fairly straightforward question, as long as you can recall which hormones are involved in the uterine cycle and the relationship to ovulation. Now, it's possible to assess when ovulation has occurred by checking one's basal body temperature on a daily basis. As we discussed before in question 1, progesterone is produced by the corpus luteum shortly after ovulation. Progesterone causes the endometrium to cease thickening and causes glands to organize, called secretory endometrium, as we mentioned in the first question discussion. In a sense, this readies the uterine lining for implantation. One of its locations of action is the hypothalamic thermoregulatory center, leading to a slightly elevated basal body temperature of up to about 1 degree Fahrenheit. That's a bit of factoid knowledge, but the way I committed this to memory is that thermoregulation is an evolutionary mechanism to improve host defenses, and raising temperature by even 1 degree can kill off some bugs that would make gestation more difficult or dangerous. So that makes answer choice E the correct answer. Let's discuss the answer choices. The other answer choices. Starting with D, luteinizing hormone. So LH promotes ovulation and progesterone secretion, but doesn't affect thermoregulation. C, HCG, or human chorionic gonadotropin, which likewise does not affect body temperature and is generally only present following implantation of the blastocyst, or in rare malignancies that are pretty high yield for step 1, like choriocarcinoma. B, follicular stimulating hormone. And now FSH promotes the growth of developing follicles, but again, does not affect body temperature. Further, FSH will be highest before ovulation and low during the luteal phase, as we discussed before. And finally, A, estrogen. Normally, estrogen lowers core body temperature, and this is important and ties into the setting of menopause. In hypoestrogenic states, such as menopause, core body temperature increases, and that's often experienced as hot flashes. This effect would not be seen in a premenopausal person. All right, so back to you, Sean. Nice work, everybody.
Excellent. Thank you, Kasha. So a rather straightforward question. Well done, everybody. Let's move on now to our last question of the evening. Let's keep the momentum going. You guys have been doing great so far. Some of the highest percentages of correct answers we've ever seen in the question lab. So very encouraging. Let's move on now to our last question. Which of the following additional serum values will most likely be abnormal in this patient? Which of the following additional serum values will most likely be abnormal in this patient? And once again, I'll give you guys a couple of seconds to let us know how many steps you think this question will require. All right, looks like a lot of you guys are saying 2 steps. And once again, Kasha will go over that when we discuss the correct and incorrect answer choices. So let's go ahead and move on to the vignette. An 18-year-old woman comes to her pediatrician because she has not had a menstrual period for 6 months. Menarche occurred at the age of 12 years old, and menses began occurring at regular 30-day intervals when she was 14 years old. On initial examination, she is 5 feet 7 inches tall and weighs 200 pounds. BMI is 31. Laboratory studies show. I'll give you guys a couple of seconds to take a look at those lab values. and you have the normal values already there for you as well. And now we will read the lead-in again. Which of the following additional serum values will most likely be abnormal in this patient? And with that, I'll hand it back off to Kasia.
Okay, great. Thank you, Sean. So as always, we're going to start this final question by trying to figure out how many steps there are to answering this question. So first, we're going to need to identify what the condition is that this patient is experiencing, and then an additional serum value that will be abnormal. And that's a classic two-step question. So let's take a look at these answer choices, starting with the bottom. E, thyroid stimulating hormone, triiodothyronine, and thyroxine. D, prolactin. C, glucose. B, cancer antigen 125 or CA125. Or A, beta human chorionic gonadotropin, also called beta HCG. So go ahead, we'll give everyone a minute or two to go over this and select their answer.
Excellent, thank you, Kasia. So our last question of the evening, let's try to finish strong. Let's see how you guys do. We'll give you guys a few seconds to respond, and then we will move on to our special offer this evening, as well as our raffles. So make sure you stick around. All right, I see the answer choices coming in. We'll give you guys a few more seconds to respond here. Wonderful. A couple more seconds here just to make sure that you guys have a chance to select your answer. And it looks like it's leaning heavily in one direction. So let's see if you guys are right. Looks like 51% of you guys picked glucose, and in second place was E, thyroid stimulating hormone, triiodothyronine, and thyroxine. So let's see what the correct answer is. And the correct answer is B. The correct answer is, the correct answer is C, glucose. So a little typo there. Correct answer is C, glucose, and 51% of you guys got it right. So great job, everybody. And with that, I'll hand it back off to Kasia. Kasia.
All right, yeah, sorry for the typo, everybody. But yes, so the correct answer choice here is C, glucose. So thanks, John. So let's start by taking a look at this vignette again and taking a look at the pertinent points. This patient is presenting to clinic with amenorrhea for 6 months after previously having regular cycles. Of note, she has elevated body mass index. That is important to identifying the first step on this question. Her labs are remarkable for an elevated testosterone and estradiol and a marginal FSH. Importantly, most premenopausal people have about equal amounts of LH and FSH during the early part of their cycle. This patient, however, has an LH to FSH ratio of 5:1. What condition comes to mind with these features? So go ahead and share with everybody present what you think.
Excellent. Thank you, Kasia. By the way, just so you guys know, next week we will be covering antivirals. So next week we'll be covering antivirals in our question lab, Tuesday at 6 p.m. So make sure you tune in.
Awesome. Okay, so I'm seeing PCOS, which is great. And I love this question. I think it's a really important one because polycystic ovarian syndrome, which many of our esteemed guests are describing in the chat, is a really important public health issue. It's becoming increasingly common and has some very important consequences or sequela that we need to be conscientious of. And that's why I think this question is so important. So what is PCOS? Polycystic ovarian syndrome usually begins during the late teenage years to early 20s. Patients will often report unusual hair growth and a deepening voice. Ultrasonography typically demonstrates multiple cysts in the ovaries. However, the presence of cysts is not actually necessary to make the diagnosis. PCOS is a hyperandrogenic state in which high levels of testosterone cause most of the clinical signs. The small anovulatory follicular cysts secrete large amounts of estrogen as well, at levels high enough to have positive feedback on luteinizing hormone release. However, the high estrogen levels inhibit FSH release. None of the follicles that develop in these ovaries are mature, so LH is unable to induce ovulation. Therefore, in PCOS, a patient would have elevated testosterone, estrogen, and LH with low FSH levels, as we see in our patient. Now, PCOS is a complicated endocrine condition with many different features. What other endocrine consequences might be present in these patients? Complications include type 2 diabetes and metabolic syndrome. Thus, glucose levels need to be measured to monitor for insulin resistance and associated complications. So let's go ahead and take a look at why these other answer options were incorrect. Starting with E, thyroid stimulating hormone triiodothyronine and thyroxine, and that is a mouthful. So this is an important kind of imposter for the correct answer choice for this question, because there's a lot of overlap between these two kind of mixed endocrine conditions. Now, thyroid dysfunction is an important condition to consider in the differential for this patient. Hypothyroidism is typically associated with amenorrhea, but would also present with other symptoms, including fatigue, cold intolerance, constipation, brittle nails, coarse hair, and weight gain, although not necessarily typically to the degrees seen here. So hyperthyroidism, on the other hand, would produce weight loss, tachycardia, hypertension, hyperthermia, and in severe cases, you can even see thyrotoxicosis with altered mental status. This patient has a BMI of 31 and does not present with the other typical symptoms of hypothyroidism. So important to differentiate these two conditions. So we'll move on to answer choice D, prolactin. Now, prolactinomas and other causes of elevated prolactin are a common cause of secondary amenorrhea. Hyperprolactinemia typically presents with menstrual cycle dysfunction, including amenorrhea, and also galactorrhea, which is like a milk expressed from the breasts. Prolactin levels are usually normal in women with PCOS, generally less than 25 nanograms per milliliter. However, it is important to check for high prolactin levels in order to rule out other problems, such as a pituitary tumor that might be causing PCOS-related symptoms. Some women with PCOS do have elevated prolactin levels, typically falling within the 25 to 40 nanogram per ml or milliliter range. Prolactin inhibits gonadotropin-releasing hormone, FSH, and LH secretion. So the patient's lab results are not actually consistent with a prolactinoma, nor does she present with any other symptoms of prolactinoma, including visual disturbances or headaches. So important to make sure that those are not present. All right, we'll go on to answer choice B, CA125. Now, neoplastic hormone production is an important consideration, and what I mean by that is production of hormones from a tumor or a mass is an important consideration in the workup of an endocrine disorder. CA125 is a tumor marker that helps assess treatment response in ovarian cancer patients and detect recurrence. Importantly, ovarian cancers are usually not active and are most common in postmenopausal patients, which is certainly not the patient that we're dealing with in this vignette. All right, and then lastly, answer choice A, beta human chorionic gonadotropin. So HCG would give an indication if this patient is pregnant. It is definitely reasonable to determine pregnancy status for any woman who is reporting amenorrhea, as it is one of the most common causes of amenorrhea. However, this patient's lab results and presentation indicate a different process is causing her amenorrhea. So, nice work, everybody, on this question. I see that a lot of people got it right. It's definitely a tough one, and requires you to really search your mind for all of the conditions that could be present to recognize versus PCOS. All right, so nice work, and that's it from me. Thanks, Sean.